Assalamualaikum. My name is Muhammad Syahmi bin Abdul Ghaffar. My trick number 930500352370001. Today I will talk about technical evaluation, findings and management of a patient with pelvic fracture. Introduction. There are many vehicle accidents happen in Malaysia. Statistics released by the Royal Malaysia Police retrieved 548,598 traffic accident reports in 2018, with just 1.1% involving fatalities. Kelantan recorded the largest number of road accidents with 1,626 incidents. Meanwhile, Selangor records 1,046 deaths caused by road accident only. Selangor is one of the states with the highest number of fatalities recorded. This is the chart of the deaths and injuries in road accident reported by state Malaysia around 2018. We can see Johor, Kedah, Kelantan, Negeri Sembilan, Perak and Selangor records among the highest number of injury and death involving motor vehicle accident. Meanwhile, wilayah Persekutuan Labuan and Putrajaya record the lowest motor vehicle accident in their state. Okay, this is the anatomy of human pelvis. On the left side of the human pelvis, there are transverse process, left wing of ilium, iliac crest, tubercle of iliac crest, anterior superior iliac spine, anterior inferior iliac spine, iliopubic eminence, pectinal line, articular cartilage, greater thoracenate of femur, lesser sciatic notch, ischial tuberosity, lesser thoracenate of femur, and left interior pubic ramus. On the right side, there are greater sciatic notch, sacral promontory, sacral in the middle of the pelvis, ischial spine, superior pubic ramus, obturator foramen, and the pubic symphysis that connect the pubic left and right pubic arch. Pelvic structure. What is a pelvis? Pelvis is a complex basin-shaped structure figure that forms the unique skeletal framework of the pelvic region and provide the space for the surrounding pelvic organs. There are two types of anatomic regions can be identified in the pelvis. First of all, the pelvic girdles. Pelvic girdles, or also being called as the hip bone, are made up of three fused bones, which are the ilium, ischium, and the pubic bones. Next, the pelvic spine. Pelvic spine located in the posterior portion of the pelvis below the lumbar spine consists of two parts called as the sacrum and coccyx. The two pelvic bones are joined anteriorly by the pubic symphysis, while posteriorly they attach with the pelvic spine to form the sacroiliac joints. Next, we will talk about the functions of the pelvis. There are three functions of the pelvis. First of all, it is the responsible bone that supports mostly the entire weight of the human upper body, stabilize it, and transmit it to the lower limbs. It is also a home and defense for the abdominal pelvic viscera as well as a point of attachment for muscles and reproductive organs, besides actively involved during childbirth. Meaning actively involved during childbirth are the human neonates must pass through the birth canal, which lies within the pelvic girdles as the baby exits the body. Then, definition of pelvic fracture. What is a pelvic fracture? Pelvic fracture injury can be defined as a break of the ring of the bones that connect your spine to the hips. These fractures are most commonly caused by high impact energy accidents, such as car crash or falls from a high place in younger patients, and incidents of falls for the elderly people. Depending on the consistency of the bone and the extent of fracture, the pelvis may be broken into several parts or only break slightly. There are two classifications of pelvic fracture. First of all, stable fracture. Stable fracture meaning single fractures happening to the pelvic ring. Pure acetabular fractures, commonly called as flexure fracture of the pelvic tummy, and chips fracture or avulsion fractures. There is usually just one break in the pelvic ring in this form of fracture, and the broken ends of the bones line up properly. Low energy fracture are most commonly stable fracture. Unstable fracture. Unstable fracture occurs when the pelvic ring is damaged in more than one region, or when the posterior pelvis, sacrum or sacroiliac complex is disturbed. The pelvic ring normally has two or three fractures, and the ends of the fractured bones do not match up correctly, or displacement. A high energy occurrence is more likely to cause this form of fracture. Malgine or bucket handle fracture and open root fracture are the example of this category. This is the Malgine fracture X-ray picture. The Malgine fracture is an unstable fracture of the pelvis. The Malgine fracture usually results from a vertical shear force causing two ipsilateral pelvic ring fracture. Fractures are ipsilateral and vertically orientated, one anterior and one posterior to the acetabulum. Meanwhile, this is a X-ray of open book fracture. As you can see, there are diastasis of the symphysis pubic and outward rotation of one or both iliac bones hinged at the sacroiliac joint, which represents the open book fracture fetus. As you can see, there are gaps between the middle parts of the pelvis. This is open book fracture. Now we will talk about the patient demographic data and general health history. He is a 64 years old Malay gentleman living in Bukit Queen 2, Jalan Sungai Lembik. He was working as a lorry driver during the incidents and have 20 years of experience as a lorry driver. He was married and have two sons and three daughters living with him. Previously, he was an active smoker with 4 packs of cigarettes per day since he was 70 years old age, but now he had stopped smoking around 3 years ago. Noted also family history taken for him were both mother and father were suffering from osteoporosis. Osteoporosis is the bone is fragile and easily break or fracture. Both of his mother and father had died caused by old age disease complications such as hypertension and heart disease. Noted also by the patient, he also having hypertension and gout disease diagnosed on him since he was 28 years old. For the hypertension and gout disease, he went to KK Sungai Lembing for his treatment. Last follow-up with the doctor at the health center was in January 2021. Currently, he was on medication like tablets amlodipine 10 mg on daily, meaning only take 110 mg one times a day, tablet perindopril 8 mg OD, and tablet allopurinol for gout 300 mg OD. He also claims he compliance to the medication given to him by the doctors and never taking other medication or health supplement, including traditional medication. He also mentioned he allergic to painkiller but not remembering the painkiller name, neither had record regarding allergic reaction sustained before. Most of the patient with allergic reaction that had went to any health facility will be given allergic card if had episodes regarding allergic reaction to any medication, but this patient don't have any records or allergic card with him. Last admission to Hospital Kuantan was in 1994 for appendicitis, and he had appendectomy surgery done during his stay in Hospital Kuantan. Last but not least, last meal recorded was during breakfast around 9 a.m. This patient demographic data and general health history are taken based on sample mnemonics. I will discuss about sample mnemonics in the next slides. Okay, the next part is documentation on assessment findings. Primary survey has been conducted on the patient. The main purpose of the primary survey done on the patient were to immediately identify 7 life-threatening injury caused by trauma injury. There are mnemonics in medical ATOM TC. ATOM TC, A meaning airway obstruction, T meaning tension pneumothorax, O meaning open pneumothorax, M massive hemorrhage, T is tracheobronchial injury, and lastly C cardiac tamponade. This is the ATOM TC life-threatening injury. The primary survey includes the ABCDE process, which is used in traumatic patient care, as well as a comprehensive approach to the rapid identification and treatment of critically ill or wounded patients. In primary survey, the components A, B, C, D, E, meaning A is airway maintenance with restriction or cervical spine motion. B, breathing and ventilation of the patient. C, circulation and hemorrhage control. D, disability, including neurologic assessment. E, exposure and environment control. The first mnemonic A is airway in primary survey. Patient able to talk full sentence, so the airway of the patient not compromised or being blocked. There are also no gargling sound, yet meaning no secretion or blood in the mouth of the patient, and trachea examination showing no deviation, indicating no pneumothorax injury occurred. The patient also being put on cervical collar to protect his spine, and one of the indication of cervical collar uses are altered mental status or level of consciousness are present with the patient as history taken from him noted there are loss of consciousness of the patient around 5 minutes after the accident happened. Second component in primary survey, B. Breathing and ventilation. Examination on the patient chest are equal chest rise bilaterally, but auscultation finding some abnormality which are reduced at entry over left side of lung. Percussion done on the patient bring normal result, which are resonance and pneumothorax or pneumothorax can be ruled out. Chest screening also be done and the result are positive over left side of the chest, suggestive to rib fracture. Vital signs such as SpO2 were 100% under high flow mask, and patients were slightly tachycardic around 52 breaths per minute, which are abnormal findings. Previously also noted by the medical team KK Bukit Group, SpO2 of the patient under room air are only 90% only, which are inadequate for a normal human being, which a normal reading of SpO2 must be 95% above. Next, circulation and hemorrhage control. Patients are being examined if there are any wound or injury such as fracture or open wound, which can lead to massive blood loss to be managed quickly. For the patient, his pulse volume was good and CRT less than 2 seconds, meaning he was not in shock, but during palpation on the lower abdomen showing tenderness over left flank and suprapubic. Pelvic spring test conduct are positive suggestive to pelvic fracture. During this phase also, a laceration wound 4 times 1 cm were found on the occipital region of the head and been bandaged. No exposed scar was seen and there are no active bleeding as blood had clotted around the wound. For D, in primary survey, disability including neurologic assessment. In disability, coma scale is being used to identify the level of consciousness of the patients. DCS below 8 indicating traumatic brain injury probably presents. For the patient, his DCS are full 15, I for verbal 5, motor 6, meaning his level of consciousness are full and no severe brain injury happening. Both of his pupils were reactive bilaterally and size around 2 per 2 mm. As for E in primary survey, E is exposure and environmental control. Patient was exposed to identify any hidden injury. Lock roll was being performed and no cervical or spinal tenderness, no bruises and swelling seen. Rectal examination showing anal tone present, meaning no spinal injury happened. After that, emergency management in ED HTAA. The first emergency management of the patient. The doctor had taken a brief history from the patient itself and his relative that came to the hospital. The history was taken using mnemonic samples, as meaning symptoms, A allergies, and medication. Past history of the patient, he had hypertension and gout. Last oral intake, the patient mentioned last oral intake was 9 a.m. Events to present, E for the component E. The patient mechanism of injury is alleged fall from the lorry around 2:30 p.m. while working. The patient was trying to climb up the back of the lorry to release the canvas covering the goods, but suddenly he feeling dizzy and blacked out. Then he fell sideways on the left side of his body and knocked his head on the ground. Post-trauma, he sustained loss of consciousness and lossy around 5 minutes, cannot remember or recall the event, as we call in medical interrogate amnesia, pain over the left side of the chest, pain over the left side of the abdomen, and lastly, feeling extremely pain over the hip region. Meanwhile, while the doctor taking history from the patient, his vital signs was taken by the medical assistant on duty at the red zone. His vital sign recorded was blood pressure around 88 over 52, pulse 113, SpO2 99% under high flow mask, and under row A, the SpO2 of the patient is 19%, noted by the KK medical team. Blood glucose level 7.2 and temperature 37 degrees Celsius. Vital signs such as respiratory rate, oxygen saturation, pulse, blood pressure, and temperature are considered an essential aspect of monitoring hospitalized patients. Besides change in vital signs prior to clinical deterioration have also been well reported, and early identification of preventable outcomes is critical to initiate early intervention. The vital sign recorded of the patient was abnormal, since his blood pressure was dropping below normal value and oxygen level also was dropping below normal value. In the pelvic fracture injury, the patient may lose lots of blood due to the damage or injury to the major nerve and blood vessel that all pass through the pelvic ring. How do we know the volume of blood loss for fracture injury? This is the volume of blood loss for fracture injury. For single rib fracture, blood loss is 125 ml. For radius or ulna, 250 to 500 ml. For humerus, 750 ml. Tibia or fibula, 500 to 1000 ml. Femur, 1000 to 2000 ml. Meanwhile, for pelvis, the blood loss was massive, meaning there are large amount of blood loss occur in pelvic fracture injury. This is the classification of hemorrhage. There are four classes: class 1, class 2, class 3, class 4. Average blood loss per ml. 1 is below 750. Class 2, 750 to 1500. Class 3, 1500 to 2000. Class 4, more than 2000. Blood volume percent is the blood loss in percent. Class 1 below 50, class 2 50 to 30, class 3 30 to 40, and class 4 more than 40%. There are many types of signs and symptoms in each class. In class 1, no change in heart rate, respiratory rate, or blood pressure, so the resuscitation requirement is none. For class 2, the patient may tachycardia and tachypnea. Systolic blood pressure may be only slightly decreased, slightly reduced urine output, around 20 to 30 ml per hour. The resuscitation requirement is usually crystalloid solution alone, but some patients may require blood transfusion. For class 3 and class 4, frequently requires blood transfusion. In class 3, the sign and symptom is marked tachycardia and tachypnea, cold extremity, significantly delay capillary refill, decreased systolic blood pressure, decreased mental status, decreased urine output, 5 to 15 ml per hour. In class 4, marked tachycardia, significantly decreased systolic blood pressure, cold and pale skin, severely decreased mental status, and negligible urine output. Next, after being taken vital sign by the medical assistant, the patient was then inserted with two large bore Tulas bore meaning 16 gauge or larger intravenous IV catheters that inserted into the antecubital fossa of each arm of the patient to begin fluid or blood resuscitation. During this process also, the patient blood is taken and be sent to lab immediately. If establishing peripheral IV access is difficult, intraosseous cannulation (IO) or central venous catheter placement under ultrasound guidance can be done by the doctors. The blood taken during the insertion of ranula are particularly for blood typing and cross-match. Blood gases and lactate level are obtained to assess the severity of the shock. Urine test and electrocardiograph (ECG) also done on the patient to rule out other cause of injury or other organ involvement. The patient hypovolemia status then was treated first with 1 liter crystalloid arrangement in injury, but it should often be followed by blood product. So the doctor had activated the major transfusion protocol (MTP) to start the blood resuscitation for the patient. When the reaction to the crystalloid infusion is transient or the blood pressure does not respond, 2 ml of crystalloid solution should be given followed by type-specific or non-cross-matched universal donors, example blood group O negative. Now this is the cannula types that's present in ED. In trauma, 2 large bore cannula needed. There are many sizes of cannula starting from 40G to 626G. 40G is the bigger cannula, meanwhile for the 26G is the smaller cannula. Each cannula are different in color coding of each of them. For 14G is the orange, 16G grey, 17G white, 18G green, 20G pink, 22G blue, 24G yellow, 26G violet. Each of them have different flow rate. The bigger size of cannula meaning the more flow rate per minute. Meanwhile, for the 26G, the flow rate is minimal only. The bigger cannula are used for the trauma patient because in trauma we need large volume displacement. So bigger cannula helping in fast large volume displacement of fluids including crystalloid, colloid and blood products. Next, in the process of emergency management of the patient. After that, while waiting the blood from the blood bank to arrive, primary survey and secondary survey were done on the patient. Primary survey had been discussed above during the presentation on assessment findings. In the primary survey, the patient was kept on spica collars and given hypomass 15 liter due to inadequate oxygen of the patient due to the clay chest condition involving multiple rib fracture, but the patient did not develop tension pneumothorax or hemothorax injury. The patient was in pain when taking breath, usually during exhalation due to the rubbing of the fractured rib, thus restricting the ability of the patient to breathing normally and reducing oxygen intake of the patient. In addition to that, due to the pelvic spring test that came out positive, the patient also was put on T-port pelvic binder. Application of the pelvic binder is a hemostatic adjunct as the management of hemorrhagic shock is to identify and stop the source of bleeding, whilst concurrently resuscitating the patient. Hence, as pelvic fracture was the main cause or source of the bleeding, it should be managed immediately. The pelvic binder has been promoted to maintain or restore mechanical stability to the pelvis and hemodynamic stability to the patient with a suspected pelvic ring injury prior to operative intervention or angiography. The reduction and stabilization of the pelvic ring is believed to decrease fracture site bleeding while protecting any initial blood clot from disruption. In theory, a decrease in the pelvic value may create a tamponade, thus reducing venous bleeding. This is the picture of the teapot pelvic binder being used to control pelvic fracture bleeding. Teapot pelvic binder is a mechanical advanced pulley system provided for quick universal compression of the pelvic region with a simple movement of the pull tab. It also provides effective stabilization of the pelvic region and reduce the pain that is associated with pelvic fracture treatment. If the pelvic binder is kept in place for more than 24 hours, skin integrity should be checked every 12 hours until definitive fixation done on the patient. Meanwhile, during secondary survey, focus assessment with sonography in trauma plus scan were conducted on the patient. Focus assessment with sonography for trauma plus scan is a point of care ultrasound examination performed at the time of visitation of a trauma patient and to identify intraperitoneal fluid in the abdomen. The scan result of the patient are some free fluid seen in suprapubic area, indicating there are intra-abdominal bleeding occur to the patient. After the first scan done, the blood were ready and available after arriving from the blood bank. The patient immediately being transfused with 2 pints of blood products. The patient blood pressure slightly improved after transfused with the blood. Hypotensive patients who do not respond to initial fluid resuscitation will need large volume of fluid in the future, resulting in hemostatic pathway deficiency. As a result, it should be expected that all such patients will need platelets and fresh frozen plasma (FFP) for every 5 liters of volume displacement. 2 to 3 units of FP and 7 to 8 of units of platelets are needed in the trauma patient. Next is the medication given to the patient. The medication also be given after gaining IV access of the patient beside fluid and blood. IV infusion tramadol run on 5 mg per hour will start for relieving the pain caused by the flared chest and pelvic fracture injury sustained by the patient. In addition, IV metoclopramide or IV Maxolon 10 mg also given as a preventive of nausea and vomiting caused by the side effect of tramadol. And anti-tetanus toxoid 0.5 mg also being given as preventive from tetanus disease caused by tetanus bacteria infection through open wound. Lastly, to stop the bleeding caused by the internal injury of the patient, slow IV tranexamic acid 2 grams had been administered to the patient. Later, the patient had been sent to do X-ray and CT scan. Meanwhile, the doctor in charge of the patient had referred the patient to the ortho and surgical doctor team for their review and management. Now, in the component identification of diagnosis and intervention for the patient. After retrieving all the bloods, X-ray and CT scan result of the patient, the doctor had diagnosed him with alleged fall from height with polytrauma sustained. First, open book fracture. 2, intra-abdominal injury. 3, multiple left rib fracture with minimal lung contusion. 4, mytraumatic brain injury (TBI) with laceration wound over less occipital region. How the diagnosis be obtained? There are 3 aspects considered when given the diagnosis for the patient. First, in physical examination. My assignment is focusing on the open fracture of the patient, and I will explain how it is being diagnosed. The patient was diagnosed with open boot fracture injury based on three criteria. First of all, during physical examination on the patient, find out pelvic spring is positive. During the rapid trauma assessment, the doctor have applying the method of look, listen, and feel for pelvic stability during the rapid trauma evaluation by compressing the ring of the bones, feeling for instability or deformity, checking for aberration or bruises, comparing limb length, and listening to the patient for the sound of crepitus, which is the sound of bone ends grinding against each other. Aggressive palpation or pressure should be avoided at all costs because it can exacerbate the issue. In comparison to the normally stable bones on the pelvic, there is instability, capital sound, and irregular movement of the pelvis during the test conduct on him. How the pelvic spring test done? During the physical examination, the doctor used the palm of her hands to apply gentle medial pressure by pushing inward on the iliac crest. We can see in the left picture the pressure by pushing inward of the iliac crest. After that, assuming the patient is supine, he applies gentle posterior or downward pressure to the iliac crest of the patient pelvis with the palms of his hand. Finally, he applies gentle downward pressure to the pelvis to test the stability of the pelvic ring. This is how a pelvic spring test was performed to determine the patient open boot fracture injury. Next, the sign and symptom. Moreover, noted also the patient sustained multiple signs and symptoms of pelvic fracture injury, such as pain and tenderness in groin, hip, lower back, buttocks, and pelvis area, bruising and swelling seen over the pelvic bone, numbness or tingling sensation around the genital area and in the upper thigh noted by the patient, pain present when sitting and during bowel movement. Next, X-ray also been used as one of the diagnostic methods to confirming the diagnosis of the open boot fracture. The two X-ray of the pelvis of the patient was shown below. This is the first one, pelvis X-ray of the patient in AD. This is the second one, pelvis X-ray of the patient in AD. Identification of diagnosis and intervention for the patient. Electromagnetic radiation is being used in X-ray image to show the position of a broken bone in the hip or pelvis. They also assist the doctor in determining whether a bone has been fractured in multiple locations and whether any bone fragments has been displaced or shifted out of position. Many pelvic bone fracture will be visible on an X-ray, but they will not reveal specific injury to the pelvic organs. X-ray includes image of the bones, and in the case of the pelvic, they are generally taken from a variety of angles, so we can see where and how often the bones are out of alignment. The X-ray result of the patient are as below. Cervical X-ray visualized up to C4, no fracture seen. Chest X-ray, 4th to 9th left rib fracture seen, no pneumothorax or hemothorax seen. Thoracic lumbar X-ray, no obvious fracture seen. Lumbar sacral, loss of lumbar lordosis, osteophyte seen. Pelvis X-ray show open boot fracture that can be seen. From the pelvic X-ray can be seen the air gap at the pubic symphysis represent the fracture happen as a normal pelvic symphysis will hold the pelvic together and no gap present between them. Besides that, CT can also use as one of the methods to diagnose the pelvic fracture with more precise and detail. Basically, CT scan involves multiple X-ray in sliced down through the pelvis in order to build up a three-dimensional image 3D of the injury that give better picture than X-ray of the patient pelvis. CT provide further information of fracture, the location of fracture fragments, the degree or diathesis of the sacroiliac joints in pubic symphysis than simple films X-ray. For the CT scan can be seen the pelvic diastasis around TCM with subjunction disruption. After being diagnosed with pelvic fracture, the patient was reviewed by both orthopedic and surgical team. They decided to admit the patient under surgical team and had made treatment plan for the patient in what such as 1. Kidney by mouth MBM with intravenous lead 5 pints over 24 hours consists of 3 pints normal saline and 2 pints D5% as a preparation of our operation as planned. Next, glucose level monitoring 4 times daily. Key IV infusion tramadol 5 mg per hour to relieve the pain. Keep pelvic binder and cervical collar of the patient. Keep high flow mask to maintain SpO2 more than 95%. Strict intake outtake IO charting and vital sign monitoring. The patient also been planned for fixation of the pelvic fracture by the surgical and orthopedic team. What are the interventions for the patient? The first step in reducing pelvic hemorrhage is to keep the pelvis as stable as possible. Binders and sheet are used at first, followed by external fixation for stabilization. The patient with unstable pelvic fracture will undergo one or more surgical procedures to fix the pelvic fracture. The procedure may include external fixation, traction, and internal fixation as one of the procedures in the treatment of pelvic fracture involving surgery. The surgical procedure to fix the pelvic fracture. Traction is a pulley device with external pins put in the bones as well as weight and counterweights are used to pull the bone, and it also helps regulate the alignment of the bone fragment. Skeletal traction is often used as a temporary treatment and it usually helps to relieve the pain. During skeletal traction, metal pins are implemented in the thigh bone or shin bone to help position the leg. Weight attached to the pins gently pull on the leg, keeping the broken bone fragment in as normal as position as possible. Pelvic fracture are still treated with skeletal traction alone. Pelvic fracture are still treated with skeletal traction alone, although this is uncommon. This is the picture of the upper femoral traction. Lateral traction for fracture with medial or anterior was had been done to the patient. Stress capsule and ligamentum teres may reduce acetabular fragments. Next, for the external pelvic fixation procedure involving long screw were placed from the sides into the bones and a wide external frame is being used. It is performed under sedation in the operating room. By keeping the bones together, it helps to prevent any blood loss. Small incision in the skin and muscle enable the metal pins or screw to be inserted into the bone. In both sides of the pelvis, they protrude from the skin and are tied to carbon fiber bar. The external fixator serves as a stabilizing frame that keeps the bones in place. This is the picture of the external fixation surgical procedure to fix the pelvic fracture. Why? In the internal fixation is very rare because only some of the cases needed it to hold the bones in place. This is anesthetic-assisted open surgery. The bone fragments are repositioned and then secured with screw or metal plates that are kept in place permanently. This is the 3 X-ray of internal fixation surgical procedure done to the patient for fixing the pelvic fracture. Next, treatment and rehabilitation after surgery. On top of that, there also other treatment will be conducted to the patient after surgery. Lights, pressure relief and bed rest are the first step of recovery, followed by mobilization. The patient will most likely require crutch or a walker for 3 months or before his wound heals completely. He will also require to use a wheelchair for a period of time in order to prevent and placing any weight on his pelvis. He also been prescribed with blood thinner medication, anticoagulants such as warfarin for prevent blood clots from accumulating in the veins of the patient's legs and pelvis. This happens due to the restricted movement of the patient, especially in pelvic fracture, which is known of high risk of blood clots to form. The patient will be seen regularly by physiotherapists who will try to help him keep his pelvic muscle strength and joint mobility whilst he are not be able to weight bear after the surgery. Last but not least, in conclusion, pelvic fracture injury are one of the life-threatening injury that can lead to morbidity and mortality of the patient. The patient may suffer negative and bad consequences if the injury not be managed properly. After recognizing and detecting the injury while doing the primary survey, especially the injury should be managed early and proper treatment should be started. Moreover, with better analysis regarding pelvic fracture injury, medical staff, especially medical assistant, will be more prepared to manage it. Bleeding control, hemodynamic restoration, pelvic ring stabilization, and a simple and precise diagnosis and surgery are all part of the treatment for a complicated pelvic fracture of the patient. That's all from me regarding the pelvic fracture injury and the management of it in ED. Thank you for listening. The presentation delivered by me.